Well, good afternoon, everyone. Welcome to another wonderful Met How at Home educational session. Here we are with Jeannie DeBoard and representing, well, what used to be Frontier Home Health and Hospice. And now is it Encompass?
Yep, Encompass.
Okay, great. And we also have Sheila Brandenburg. Sheila was here. Am I?
I'm here.
Oh, good. You are there. I'm just marginally able to see everybody with the Okanagan Palliative Care Initiative. And also, yeah, we have all kinds of wonderful people here. So I'm going to turn this over to Met How at Home. And Betsy, you're involved with so many things. I'm not going to list them all up right now, but I'm going to hand it over to you, Betsy, to do any more introduction of the program, and then we can have Jeannie and Sheila introduce themselves.
Terrific. We have had some questions about the differences between palliative care and hospice, and the differences, while really important, I think it's also to remember that the two systems are very much aligned in purpose, which is to make sure that people have a voice in their care and receive the care that they want when our health goes sideways, as it sometimes does. So we are really fortunate to have resources in Okanagan County that many people don't. And the Okanagan Palliative Care Initiative and Confluence Health both are represented here. Karen Jacobson and Sheila Brandenburg are working with Okanagan Palliative Care, and Sheila, as some of you have experienced, works with Confluence Health as well. And Jeannie has been in the Valley doing the work of hospice for many years and has served our community incredibly well. And we're just really lucky to have these people available to us. So I don't have to say a lot more. I'm grateful to them for sharing their experience and perspectives here with all of us, and I will stop talking. We may want to hear from all of you a little bit about how you chose to decided to come to this meeting, but we'll see how time allows.
All right, well, I'll jump in. So I'm Sheila Brandenburg, and I'm a hospice and palliative care certified nurse. I've worked with Confluence for the last 4 years, developing a palliative care service line for Confluence Health patients. And then for the last 3 years, I've also been involved with the Palliative Care Initiative, which is a local Met-How group of providers that includes doctors, EMS, nurses, behavioral health. And we are grant funded trying to initiate palliative care throughout the county. It's a slow process because there aren't many palliative care providers in Okanagan County. But we're hoping to bring this service to the county. And I'm going to let Jeannie introduce herself, and then we'll start with kind of just introducing the idea of what is palliative care. Jeannie?
Thank you, Sheila. So I'm Jeannie DeBoard, and I'm a social worker, and I have worked with actually now going on the 4th company, but I started out with Okanagan Regional Home Health and Hospice. And Sheila and I once worked together. She was a nurse and I was a social worker. As things evolved, and then we were bought out by Amedisys, and then Frontier Home Health and Hospice, and now just this month, Encompass has purchased us. And Encompass is the fourth largest home health and hospice in the nation. And so we're in like 32 states. And so it's going to be a learning curve for all of us, but I don't think our patients are going to see much difference. So anyway, I've been with hospice for 25 years. And we cover the entire Okanagan County, but my territory is mainly the South, Twisp, Brewster, Grand Coulee, and Okanagan. So I get to work a lot up in the Methow Valley, and it's always an honor because people are such good volunteers up there, and it's just such a unique community. So I'm glad to be part of that.
Thank you, Jeannie. So I just introduced what palliative care is. How many people already know what palliative care is or what we do?
Pretty much.
Well, good. That's like 1.5 people. Most people don't actually know what palliative care is. It's a relatively new area of nursing or of medicine. The purpose behind palliative care, the intention behind it is to support any person with a chronic or serious illness, any stage in that illness, any age, any part of the process. So I often see people who have just received a new diagnosis and are having a lot of anxiety and fear and a lot of questions. I also see people at the end of their life who, for whatever reason, have chosen not to go into hospice, and their family wants to keep them at home, and they're working through the process. I also will help them as well. It's a multidisciplinary process. So there are physicians in our palliative care team. There are nurses. There's currently we have EMS has a presence in our palliative care initiative. There are social workers, spiritual people, behavioral health. So we try to encompass and wrap around the patient and the support team. And that can be family, it can be friends, it can be community, to help with symptoms, questions, navigating the healthcare system. Many of you know that can be really hard when you're working inside of these big organizations about how to get to where. We do a lot of different things. I mean, I have delivered wheelchairs or walkers. I've, got somebody a medication and brought that to them and teach them how to use those. And so it's a lot of different things. And what I'd really love to know is kind of what are your questions and what brought you here today? But it might be helpful for Jeannie to talk about hospice, and then we can go back and forth to answer those questions.
That sound
Jeannie,
okay?
do you want to?
Sure.
Yeah.
Sure. So hospice, and people think hospice is a lot of different things, and so it is very similar to the palliative care, but hospice is it's a way of caring for people that have a terminal illness, and to focus on eliminating their physical symptoms such as pain, shortness of breath, nausea and vomiting, as well as eliminating their spiritual and emotional distress that goes along with dying. And then there's a bereavement program that is part of the hospice program that follows families for 13 months after a loved one has passed. And our bereavement coordinator is Boo Schneider, which maybe some of you people know her up there. And so she will make phone calls and send grief literature. Like every month, she will send letters out, just normalizing the grief process for 13 months. And if somebody needs an additional phone call or something, she will call them. And then she has support groups that she has once a month. And so that's a requirement of the Medicare conditions of participation, is to have a bereavement program. And so hospice is it's a philosophy that hospice believes that death is a natural part of life. And its focus is on, we don't hasten death, we don't postpone death, we just help the loved one and their family walk their journey, and just focus on life and quality of life, and it's defined by them, what's important to them, and so how they can live their last days as fully as possible. And so it too is an interdisciplinary program that comes. We have a medical director, and our medical director is Dr. Jennifer Thill, and then an attending physician is often, as part of that team, and then nurse who is a case manager and manages the case, and then social worker, and I'm the social worker on our team, and my job is like long range planning, emotional support, and community resource utilization, or anything else they're needing. I will try to find out if I know about it. We have an aide that can come in and do bathing, and do a little light housework. We have a chaplain that his name's Sam, and he's in a non-denominational role. And I don't know if that so I keep getting these texts and they're covering my face. So I don't know if it's covering my face on your screen, and
No.
I apologize.
No.
Okay. I just keep flipping it up. Anyway, and then we have volunteers, and so our volunteers are, they go through a training, and they can't do personal care or anything like that, but most of the time our volunteers will do respite care, or they can do light housework, they can run errands, and we have we always need volunteers, but we have a few volunteers up in the Methow area, and it's wonderful, and they oftentimes get to spend more time with the patient and their family, and it can be really rewarding. So that's the team of hospice. And then how it works is typically a person who, to qualify, they have to have, doctor has to certify that they have a 6-month or less prognosis, and that is best guess and Medicare rules, and we are bound by Medicare rules. It doesn't mean only Medicare is the reimbursement source, but our guidelines are by Medicare. So when I talk about Medicare, I'm talking, the guidelines. And so they require that the doctor would not be surprised that this person is gone in 6 months, but it doesn't mean that a person has to be, if they are still with us in 6 months, we kick them off. So there's just a progression that we have to watch for, and to make sure they qualify. And then they have to be aware of the focus of comfort care only. They do not want to go back to the hospital anymore. They do not want any more curative treatment. They want to focus on quality of life and stay in their own home, or in their home in a facility or resident, and no labs, x-rays, just focusing on the symptoms that are causing them distress. And if they're having shortness of breath, we're going to treat that. If they're having pain, they're going to treat that, but we're not going to do labs, x-rays to figure out why. And once they meet that criteria, they have to have a caregiver as well, because we are intermittent. We come in and out and teach the family how to take care of their loved one. So we don't go in and stay. And so that's a critical piece with the hospice, unless they are in a facility like Jamie's place, or a nursing home, which we are not contracted with any nursing homes in the Okanagan County, but we do work with all the adult family homes. And anybody can make a referral. If someone is questioning whether they qualify, they can call us and we'll refer them. Really, we need a doctor's order. And so they can call and talk to us. We can give them information and have them call their doctor, and their doctor can call us and make a referral if they feel like it is that they meet that criteria. And I'm trying to think about the referrals is sometimes, so there's very specific criteria that we have to go by, like most of our diagnoses that we work with typically are cancer, but anymore it seems like we have a lot of heart and COPD. But I'm going to just kind of touch briefly on this will help you to understand why Medicare cares about these diagnoses. So once a person has elected hospice, then the benefit, whether it's Medicare, Medicaid, their private insurance, they're all different. But most of the times they go by the Medicare rules. They elect their benefit, and then we're responsible to pay for everything related to their terminal diagnosis. So if they have cancer, we're responsible to pay for equipment and supplies to any supplies that they need, medications to keep them comfortable, and durable medical equipment and all the visits. And so Medicare, we bill Medicare once they elect that benefit. We bill Medicare like $180 a day. We don't get that, but that's what we bill. And with that, we're responsible for those, and we're contracted with certain companies. And so everything's got to go through us. So once a person starts on hospice, then they use the companies that we're contracted with, and everything's just got to be authorized by us. So back to the disease piece is that Medicare, the reason they have this criteria of a 6 months or left, we have or less, is we have 2 90-day certification periods that the doctor must certify that they still qualify for the program. Because if Medicare they care about the money, we care about the human. But if they are paying a daily rate, we have to justify that a person is terminal and they're not chronic. And so when someone has a cancer, it's the trajectory is pretty downhill oftentimes. But then the COPD and heart people, sometimes they are up and down. And so there's or Parkinson's or ALS or other diseases, they have to be at a certain phase in order to qualify, because they have to be at that terminal phase. And dementia. So Medicare puts out criteria where a person would probably qualify for that hospice program under that specific diagnosis. So I'm trying to think if I've touched on everything else. It's 100% paid for generally by the Medicaid or the Medicare, and they don't get a bill. But sometimes, because it can't go, the rules are you don't go back to the hospital because the hospital is of a curative nature. Sometimes people feel like they're giving up, and they're not giving up. We just remind them that they're choosing how they want to spend their last days, either going back and forth to the doctor or do they want to remain at home. So they have to have an understanding of what it is their goals are when they do sign on the program. And I just lost my train of thought here. Anyway.
Jeannie, I might add that there have been several studies that have looked at length of life with end-stage disease of people who are receiving active treatment and people on hospice. And the people who have chosen hospice have been shown to live, we're not talking about years more, but we're talking about a few months more often.
Yes. And that is
an interesting observation to say that while more limited treatment might be seen as giving up, there appear to be times when addressing comfort may actually be the more active treatment that's important.
Exactly. Exactly. Yes. And thank you for that. Yes.
And another
so,
thing that,
no,
Go
go
ahead.
ahead, Sheila.
oh, I was just going to say, the other piece that comes through really strong is that both palliative care and hospice services, the primary focus is what is it that the patient and their support team want to happen? How do they want this time of life to be enjoyed and participated in, and how do they want that to go? It's that patient's voice is really important to both of us.
Absolutely. And sometimes, I mean, everybody's so individual that as long as they're within the philosophy of hospice and they want that comfort care, as we tell them, they are in charge. Their job is to let us know how they want this done, and what's important. And I often ask people, is it important that you know what the details are that the nurse is seeing, or are you a person that doesn't want to know what the nurse is seeing, or and they're, they'll let us know, and we tell them we need your feedback and what's important. Or sometimes they want to take a little trip, and so we help coordinate a trip to go see their family. And if we have to do a traveling hospice, we will connect with a hospice where they're going to be for a while, and get them set up over there, and then they come back, and so they can do those things, those one last things that they want to do. And the one thing that I want people to know, that once they sign up on hospice, it's not in cement. If they decide there's something out there, another treatment out there, they can sign off at any time. And when they explore that and they decide that they're ready for hospice, then they can come back and get back on the program. So just because you sign up does not mean you can't sign off.
And he and I are now working collaboratively with some patients who have gone on to hospice. They come off hospice, and then I'll see them for palliative care for a while. And then we can assist with that transition back if they need to. So we work in partnership now a lot more.
We do. And it just works so well in the community that we're working together as a group, because we all do these different but alike things. Yes. And run across the same people.
Yeah.
And sometimes people think that I'm not ready for hospice. And what Sheila does a lot is to help people understand that what does that mean, ready for hospice? They think they have 3 days to live, and that's what hospice is. And so we do a lot of education and letting them know the earlier they can get on, the better we can help them to have a quality of life that they choose.
So how about questions? Does anybody have any questions or concerns or things that brought you to this presentation that we might be able to clarify?
Do they pretty much go by
I have a question.
forms that you have filled out, et cetera? Will they look at that a lot? Because all these different forms have, you want to be resuscitated, et cetera, et cetera. And are you mostly interested in comfort care or what?
Yeah, Denny, that's a great question.
Mm-hmm.
And as I said, we very much want to empower the voice of the client and their care team. So those forms are very important to us. Both what your requests are for resuscitation, also who is the power of attorney for healthcare decisions, so that that person is well informed. And also we'd love to have what we call goals of care conversations with people. Like, what is it that you're hoping for? How can we make this the best time for you? What things are you hoping to enjoy? So the patient's voice is very, very important to both palliative care and to hospice.
And that's the one thing that we do look at are their goals and those forms. And a lot of people have had the conversation in the hospital or with their doctor, and they come with the physician's orders for life-sustaining treatment, otherwise known as the PULSE form, if you're familiar with that, which is a form that allows them, that says, I do not want to be resuscitated. And there's like 4 parts to it, or I do want to be resuscitated. They do not have to have a do not resuscitate to start on the hospice program. But it kind of goes against the philosophy, because if they want to be resuscitated, that means they need to go back to the hospital. But sometimes it's just a matter of educating them. What does that mean? And what does that look like? And eventually they will change their mind, but it doesn't mean that they have to be a do not resuscitate in order to start on the hospice program. We begin that conversation.
Alyssa, did you have a question?
Yes, well, a question and a comment. I'm just curious. I've had some experience with hospice in the past, and I know that people often leave it till very late. That was the very frustrating part. They would wait for 24 hours before the person was passing. And I'm wondering now with palliative care, is the transition better? Are people more likely to, because you've embraced them earlier and explained things and they feel more comfortable, are people now going into hospice at an earlier time and getting all the assistance? And that's the other thing. I think hospice offers so much in the way of simplifying people's lives, billing and everything. And I think it's just such a wonderful, well, not secret, but I mean, more and more people are learning about it, but I think it's such a wonderful thing to have. And I just think people should go in earlier, but is it happening earlier?
Well, I know that because of my background with hospice, and then also what I do now in palliative care, I see people oftentimes much earlier in whatever the disease process is. And I explain right up front the difference between hospice and palliative care. And I kind of explain some of the particulars about hospice, because there's so many people that don't quite understand it. So in my practice over the last 3 years, I see people starting to move towards hospice sooner if they've been a part of palliative care, because it feels like in many ways it's a continuation of what they've been experiencing, which is what I hope that we get to, that people feel that we're all part of the same team. Jeannie, what's your perspective?
I wish we had statistics, but we don't. But what I have seen is, I agree with Sheila, is that some of those people that aren't ready, when they hear it from Sheila, because they've developed this relationship with her, that I think they trust her and they understand what the hospice means. And so some of those people that she's worked with when we've gone in there is that they have a little understanding of what hospice means, because Sheila has had those talks with them, and it's not been a 5-minute talk when they're in the hospital and and they come out. So I do think that has made a difference for some of those people that have been really challenging to get on early because they have the benefits. The other thing is that we also have those people that when we see them and we do the education, and maybe they haven't been involved with Sheila or anybody, is that we now have somebody that we can say, they say, I really am not ready for this, but I understand it, and I'll let you know when I'm ready. That we can say, there is this program called palliative care, and if you would like us, we can make a referral to them. And so when they're not quite there, we've got somebody else to send them back to, that it isn't all or nothing. It's like you say, it's a continuum. So I feel like I have seen people getting on earlier, especially the challenging ones. And so, but it would be good to have a statistic.
I have a question.
Yes.
I have a question about reimbursement for palliative care. I heard, this was listening to a talk, and I was hearing that palliative care isn't always covered, and that didn't sound quite right. And so I need the horse's mouth to tell me the truth about this.
Well, in some ways, that is actually true. Palliative care, because it's a multidisciplinary team, currently, the only part of palliative care that's reimbursable is that part of the service that's provided by physicians or nurse practitioners. So for instance, as a nurse, when I'm out visiting patients, my time is not reimbursed by Medicare. Palliative care as a service line is growing in popularity, and especially through the pandemic, there have been some changes in the way that Medicare is looking at palliative care. And so they are now working at the federal level about looking at reimbursement for all parts of palliative care. In the state of Washington, there is a palliative care project that is working to reimburse palliative care in the Medicaid population. And part of the emphasis there is that what they do know, and they know this statistic wise, is that huge amounts of money are saved when people don't spend the last month of their life in a hospital, or when they are able to make the medical choices for themselves and they choose to be at home. They see that saving of money rather than spending of money. So my answer in short to Betsy's question is parts of it are reimbursable and parts of it are not. The palliative care initiative that we're starting in Okanagan County, we're working under grants that we secured over the last 3 years. So right now that service is just part of what we're doing.
And
I did want to add.
Go ahead.
Oh, I just wanted to throw out this, which was related to the last question, and that is 75% of people, this is a statistic we use in honoring choices with advanced care planning, 75% of the population chooses, if they could choose, to die at home. But the reality is it's about 25% that actually get to die at home. And one of the reasons is there's not a lot of pre-planning, and people end up in crisis, end up in hospitals and nursing. So palliative care and hospice, the work at Met-How at Home, we're all focused on helping people gain information and make decisions that allow that goals that they set to come to fruition. And Jeannie, I'm sorry I interrupted you.
No, you didn't. No, this is great. It's just right on there. And speaking of the palliative care, and in the state of Washington, for the children, and I believe that is the Medicaid program that you were talking about, that they have the palliative care program that families can be on, those children can be on hospice and still seeking treatment at the same time. And so that has been some progress made with the
absolutely.
I have a question. Yeah,
Yes.
that's such a great point that you bring up, Sheila, about, these facts and figures about the percent of people who would choose to be able to die in their own home, and then the percent that actually do. And so I guess from both of your perspectives, what are some of those important pre-planning things that you could do? And also, I've borne witness to what it took, to keep my grandparents in their homes. And it was a lot of hands on deck. And then I also saw instances where there was only like really one pair of hands or two pairs of hands on deck. And it took an enormous toll on the caregiver's mental, physical health. And so how do we help our caregivers, because it's a big deal. And just wondering how often that intermittent hospice care is. How often is hospice coming into the home?
So it's based on need and or what they want. Like some people, they are more comfortable and or they're in the earlier phases and they just want a nurse coming in once a week. But a bath aide can come twice a week, and social worker as needed, typically 1 to 2 times a month. But it's based on their need. But when a person is getting closer to the end, when we consider them imminent, then we put them on what we call tips, and someone goes every day. So it gives them that support. But some people need more support than others. And that's the challenge is that you do have to have a support system to make this work at home. And so when you have somebody who lives by themselves, and we have the talk about what are you going to do when you need more help in the home, and it can be so challenging because it's so hard for people to, we know what it's going to be like, but they don't know, and they think they'll be fine and they won't need this, or I'll do it this way, or yes, I do need help, but there's no help out there because either they can't afford it or they fall in the Medicaid that pays for help in the home, but there are no caregivers, and then there's limits on what those caregivers can do. So ideally it's best to have that support system, but that's where planning ahead, like Sheila said, is really important.
Yeah, so the main thing, like we provide palliative care, Met-How at Home, Frontier, the clinics. We all have advanced care planning tools. We have people who are trained to help support advanced care planning. But the most important thing is the conversation that you have with your loved ones, your friends, your community, surrounding of what are the resources, what would we do when we have this problem, how do we cope with someone, for instance, in the family who has dementia, who at some point will not be able to live alone. Who's going to wrap the services around that person to be able to care for them in any setting? We have, we're lucky in the Met-How to have Jamie's Place, which has 2 homes. We have lots of community members who are really good supporters of people who are living with these diseases. But I definitely encourage people, get your advanced care plans in place, talk to your healthcare agents, talk to your family members about how you would want to be cared for in the event of a medical issue. Other questions?
What do you do for, ending in chronic pain? I know you can give morphine or something, but how about when you come in once a week, and can daddy give them some morphine? Can they give themselves some morphine? Or, if someone sees you once a week, it's not going to really keep them into what they call comfort care.
So, like I say, that is usually in the beginning phases. But if the nurse will educate them what to do. We also have 24-hour call, and so they have access to a nurse 24/7. But we want to prepare them so they don't have to use that if they don't need to. But if they're educated, and usually like when we start somebody, it's really overwhelming, and so a nurse will, oftentimes it's 2 times a week. I would say it's probably an average of 2 times a week, but so it varies. We minimally have to go once a week. And believe it or not, we've had people say, I don't want you to come but every 2 weeks, but they have the medication, they know how to take it. And if their symptoms get out of control, then they call us, and then a nurse would walk them through based on a doctor's orders. Everything we do has doctor's orders, would walk them through what to do. They can go up a little bit, try that. And if not, if a nurse needs to come out, the nurse can do that. So they do a lot of educating. And so someone who lives by themselves, as long as they can manage that, that's great. But when it gets to where they need a little more help, or the caregiver, is not able to do it and needs more help, and we need to increase it, we'll increase those visits along the way. And sometimes we'll have a nurse like on a Monday and an aide come on a Tuesday, and a aide, the nurse on a Wednesday, and an aide, on a Thursday, so that we've got 5 days covered, a nurse 3 times a week and an aide twice, and then they have somebody coming in every day. Now, the other thing that I did not mention is, this was pre-COVID, and we're not quite there yet, is there's different levels of hospice. So if we have respite normally when we're running under normal conditions, so we are contracted with the hospitals, and somebody could go stay there up to 5 days for respite if a loved one wanted to go, had a function that they needed to go to and they couldn't take their person, or they just needed a break. We will pay for them to go into the hospital under respite, and we follow them there, and they're on our care plan and everything. And then they can do that once every certification period. And we utilize that a lot. But we haven't been able to do that with the COVID because they haven't been able to take them. And then there's what they call, so if a person's symptoms were out of control and we did everything in our power to try to get symptoms controlled while they were at home, if we called the hospital and said, we have a hospice patient coming in to get symptoms managed and get them right back home, that's another level of hospice. Rarely do we do that, but that's another level that we can utilize to get somebody's symptoms under control. So we rely on the family we teach them, and we rely on them to be watching the medication, watching the symptoms. If things are progressing, let us know before like a weekend. Make sure you have your medications filled on the weekends, because it's a challenge out here in the rural America with no 24-hour pharmacy. And our doctor, Dr. Thill, I say she doesn't sleep. We have access to her. We can send her a text, a ping, it's a secured text site, but almost any time, and she responds. So we are so blessed to have her as our medical director, but we just have easy access. So
Denny, I would just like to clarify that we understood your question. Are you talking about somebody with pain at the end of their life, at the very, very near the end of their life, where they needed frequent dosing of medication?
Well, once they're on palliative care, for instance, there's probably not the time to worry too much about this poor guy getting addicted. No. And, you always hear that that's a main concern, but in the last couple of months of your life, who cares if you're addicted? No, it's to stay out of chronic pain, I think that the other thing that hospice and palliative care have really worked hard to develop is systems of delivery of medicine for people so that they can take it orally or through their skin, or through a way that doesn't require some technical apparatus to deliver the medicine. That's not always true, but that's usually almost always true. And that means that you can call. I think Jeannie's point about, and this, I'm sure Karen and Sheila would agree, that using the telephone as a tool to make sure that you've got the support you need is really important. Using and complaining before you're out of the medicine or things are out of control.
Yeah.
The
Absolutely.
unfortunate thing is, like, when you say to plan ahead, and that's one of my biggest struggles, is because, like I've said, that I know where people are going to be, but they don't know. So when I see that they're going to need help in the home and they don't have money to pay for it, and I want them to apply for Medicaid so they can get that process going, because Medicaid will not pay for you in a facility unless all the process is done. And it takes weeks. And so that is a challenge, because some people, they just don't want to do that. And the next thing we know, we're in a crisis, because now they do need the care and maybe they can't fill out that application. And so, then you're scrambling. So it really, you do have to anticipate and plan ahead the best you can. And just to help people to walk through that, because you can't make people be where they're not. So those are the challenges that I see.
This has been so
Yeah,
informative.
I just wanted to let Denny know that in palliative care as well, we now have providers. So a physician and a nurse practitioner that work with palliative care patients who have years of life left, but pain is a serious issue for people. So it's not only at the end of life that we want to address pain. And historically, pain has not been managed very well. So we can get people consults with those physicians.
And
Sorry.
it seems
Now
like,
you can talk to.
Go ahead,
With
Jeannie.
your hands.
I know, exactly. We have to give our hands. Go ahead, Jeannie.
oh, I was just going to say, in the pendulum swings, it was there for a while. I mean, it was a really important focus that patients in nursing homes and elderly, their pain was managed. And then the opioid crisis evolved, and it can be a real challenge to get the medication that you need. The doctors they're responsible for that. And so it is sometimes hard if you don't have that, that advocate to get your pain under control, because they don't want to just, they've never just given the meds, but they just have to be really careful.
Mm-hmm.
What are some resources or advice you might give to caregivers just to really help them through bearing witness to pain of a loved one, and just being there day in, day out like that? And what are some things that you've seen that have been really helpful?
Well, one of the things is that they take care of themselves, and that is really important. And most of the time I tell them, people can't do this by themselves. They do need that support. But it's a lot of education too, is to just let them know that they're doing a good job, and to let them know that being present, they feel like they're not doing enough, and letting them know being present is enough. And they're doing what they can. And if they can't do it, it's also okay to reach out and ask for help. But also, we encourage them to talk through their feelings with us, and sometimes just to be able to vent to that neutral person makes all the world a difference for them to be able to keep going. But so many times they question what they're doing. Am I doing enough? Am I doing the right thing? They're not eating, so therefore I'm not doing my job. And so a lot of that, just educating them on the process and that they are doing a good job. Or if they can't do it, to reassure them it's okay to say that. And then we go to plan B.
It's great. Thank you.
Yeah, I think using resources like Mental at Home and the Lookout Coalition, your medical providers, asking for support. There's a lot of really great books on caring for people with illness, the end of life journey, death and dying. Certainly if you know yourself or someone else, ask for a palliative care referral. at least let us introduce ourselves and see if there are things that we might be able to help with. Talk to friends, to family, let everyone know kind of what's going on for you. You're not really in this journey alone, although it does feel like it. And especially over the last, 16 months, we've all been sort of separated, and it's hard to be in community. But I really appreciate the platform that we have with Methow at Home that allows us to talk to community members. And these conversations come out of people's request for information. So that's what we're hoping to continue to provide.
Oh, and I can't tell you how many people that I've worked with, and they'll say, oh, I'm connected with the Methow at Home, and I, use them, call them and use them, because you need that support, and that's what they're there for, and they like to do that. So, and the Guardian Angel program, there's just so many good programs, lacking caregivers, but the volunteers in the Methow, it is wonderful to be able to have those to draw on.
I'd like to just highlight also the skilled human support that both these programs provide. I think illness makes people raw, and we're all imperfect human beings. So when we're hurting and also dealing with grief and loss, we aren't always problem solving or dealing with our caregivers or ourselves as best we might. And both these programs have really great resources for trying to support you. Not that they fix everything. Yeah. Everything doesn't get fixed.
No.
But at least they can help with managing some of the feelings that come up.
Absolutely.
One of the most important things I got from Raleigh was that we all want to lie down, take a nice nap, and not wake up. But only 10% of the deaths in the United States are that fortunate. So the rest of us are going to go through some wonderful skip and jump agony or something. And so all these programs are just so important and can be so helpful. I think the caregiving is going to be the most difficult. Like I have no children living close at all. They're all spread all over the place. And so that is a concern. How if you need some caregiving, and the cost, I know last I checked was about $25 an hour for a full-time caregiver. And that would last, about 3 days, so.
Yeah. And so that's where, there's really a, you've got to have some finances to be able to pay that at 24/7. And it's now $30 an hour typically if you go through an agency, and I think it's even up to 32 if you private pay for an agency. But then there are state programs once you spend your money down to help qualify for caregivers or to help you to be in a facility. And so that's where social workers come in to let you know what those resources are and help to prepare you for that.
And hopefully, there's some big bills that are going to be hopefully going through the legislature to provide a lot more support for things like exactly this.
I hope so.
Yeah.
Yeah.
Yes, because we are in a caregiving crisis. I really, we had more adult family homes and than we do now, and more available caregivers. And what it's all about, I don't know, but it is tough out there.
Any other
Any-
questions? Oh, sorry, Denny.
No, I was just gonna say, is there any, has anyone heard of any plans for assisted living building in the Methow Valley? There was a beautiful one all planned, had land and everything in 2008, and that all
Yep.
fell apart.
So Jamie's place is leading a discussion that includes alternative housing for elders. It's not likely to be something that happens instantaneously, but there's more discussion again around it. And it's good to hear you all. Actually, I should give you a heads up. There will be a survey coming out that hopefully you all will participate in about your needs and interests and around housing and as well as caregiving.
Mm.
Any other questions?
And if anybody has any questions when we end this session and they're like, oh, I wanted to ask, please call. We're glad to answer any questions.
Yeah, this has been really informative. I'm really grateful for everybody taking the time here this afternoon for this. If anybody is opposed to Met How at Home sharing this session on our YouTube channel, can you raise your hand right now?
Nope.
Okay, great. And so I'm going to make sure that this is available for other folks.
I just want to say thank you. I have been actively listening, even though I put my photo on the screen so I could get up and down and not worry about moving around. So thank you all.
Thank you
Wendy.
for listening.
Thanks for having this. Onward and upward.
You're very welcome.
Yeah, it's important to know our
Thanks, Carly.
resources. So thank you so much, you two, and everybody, Betsy and everyone for being here. It's great to see you all this afternoon. So
Thank you, you
care
too.
out there and
Okay. Okay, thank you.
Bye-bye.
Bye.
Thank you.
Thanks for your great work,
Hello,
and
Carly.
Jeannie. Bye-bye.